Well, good morning, everyone. It's a great pleasure for me to introduce, on behalf of the Departmental DEI Committee, our Grand Round speaker for this morning, who is, I think, known to just about everybody in our department. Um, Dr. Mahmoud Khalifa came to us in 2014, and when I was looking at his CV, it surprised me because he has accomplished so much in the not quite 10 years that he's been with us. So I'm going to just give a brief introduction. Dr. Khalifa did his medical education and his PhD in Egypt, and then moved to the United States for residency at the University of Oklahoma in anatomic pathology. And then after a year at Georgetown University, he moved to Canada, first to Newfoundland and then to Toronto, where he rose through the academic ranks to full professor and led a very large group of surgical pathologists in Toronto before Dr. Firk was successful in recruiting him to the University of Minnesota as the Donald Gleason Professor, and at that time the director, now vice chair of anatomic pathology. I think it's safe to say that Dr. Khalifa really transformed anatomic pathology in our institution. He did this by supporting the young faculty who were currently at the department when he arrived, and also recruiting a very talented group of anatomic pathologists, including a new director of surgical pathology, Dr. O'Day. So we have been so fortunate to have him leading our AP initiatives in the department. Dr. Khalifa has been interested in gynecologic pathology since his residency, before his residency in medical school, when his PhD thesis was on the topic of ovarian cancer. And more recently, he has transformed his interest into transgender pathology, becoming a nationally recognized expert in this area. So this morning, we're very fortunate to have him talk to us about transgender pathology, our current state. Thank you very much, Mahmoud.
Thank you, Debbie, for the introduction. Yes, I was fortunate to be part of this group, and the support I get from leadership and Dr. Firk was quite instrumental in my career. I will talk today as part of the DEI initiative. I will be talking about transgender pathology. I have no financial disclosures. I want to start off by saying I'm just one person. I'm not advocating for any demographic group. And I'm going to address the topic of transgender from the pure pathology perspective. Unfortunately, this is inherently a political topic, and no matter what you do in this area, and that probably is part of my messaging today to my colleagues, is that we are in this, and no matter what we say and no matter what we do, it is going to be slightly political. We just try to be careful. The reason I got interested in this is because there was a knowledge gap that I realized with myself and my colleagues. The knowledge gaps were mostly in the area of terminology and the language we use, as I said, to be appropriate when we speak about the topic. The range of the expected histologic findings, I will talk a little bit about that as well. Documenting tissues, and I will talk about the consideration for subsequent screening for transgenders. And most of this topic focuses on lab administration and compliance issues, and I think our department has some good experience in that field. I will start by saying that approximately 0.6% of US population identify themselves as transgender. And the number of individuals seeking gender affirmation surgery is steadily increasing, and we certainly see that in our department. Once the person identifies as a transgender and they start seeking medical help, they go through what is known as medical affirmation. Medical affirmation typically means administration of sex hormones that will help the transgender reach the gender of their choosing. And then that follows by what we call surgical affirmation, which is the surgical procedure that will make the final transition. And this is where we get involved because these surgical materials are sent to us. So if that is the sequence that we put as the backdrop of our discussion and our practice, it is important to know that about 71% of transgender actually do the medical affirmation, just 70%. And out of those, the number that goes all the way to surgical affirmation certainly is much, much smaller. So when we talk about in surgical pathology about transgender, we are talking about that very small segment that typically finished their medical affirmation and then went through surgical affirmation. And when we receive these specimens, typically we receive them from young individuals, and the average age, as shown here, is 29 years. So what is really happening around us? So we start with the transgender group, which is a subset of population. And I want to highlight that this subset has very special emotional needs. They have very special medical needs and physical needs. And while transgenders are trying to deal with their needs, obviously politicians jump on the issue and they make it political. And of course, there are legal aspects of the topic. And of course, religious people also have to chip in. And of course, like everything else, it has economic consequences. So all of this is happening around the transgender population. And here we come as part of the healthcare system that is going to take care of these individuals. And within the healthcare, we are in pathology. What do we do in pathology? We do what we do best. We go back to our microscopes and start to understand the tissues. So it all started back in 2016. We had a surgical pathology fellow by the name Mohammed Al-Haj. He came to me and he said, what's going on with transgender specimens? We are getting so many of them. He came to us from Cleveland, where he wasn't used to seeing these specimens. And as I mentioned, by the time we get the surgical specimen, the individual already went through medical affirmation. So they received large doses for a long time of sex hormones. So the tissues we receive has changes relevant to the hormone administration they receive. This is something that we haven't seen before. Yes, in every pathology textbook, you can read about effect of hormones on this tissue or that tissue. But I don't think any of us has seen systematically the effect of hormone or studied the effect of hormones on whole organs the way we see them in transgender. So he said, this is a unique opportunity. Why aren't you studying this? Why aren't you studying this, what used to be a theoretical concept of hormones, in a real life situation where they are actually seen in these tissues? And he opened the door for me. And I was blown away. I was actually blown away by the amount of information out there. And I was blown away by how little I knew personally about the topic. And I started studying these tissues. Let me start by saying that today, there are 19 states in our country that ban gender-affirming care. You can't even get counseling or social counseling for transgender in these 19 states. So this is the landscape where we are operating today. And of course, if you look at this map, you can see why we here in Minnesota get a large number of transgender specimens from our neighboring states. And transgenders typically come to Minnesota and come to other states that can give them the care they want. Interestingly, in these states, there are actually harsh penalties, even that would be given to any healthcare provider who provide healthcare support. That is why the World Professional Association for Transgender Health was established in 1979. And this is an international organization, multidisciplinary professional association whose mission is to promote evidence-based care, education, research, public policy, and respect for transgender across the globe. And they have many publications. You can look at them on the web. And this probably is the source or the nucleus of everything that I will be discussing today, and everything that anyone interested in transgender care can find resources on their website. I want to start by the term gender dysphoria, because gender dysphoria is defined as it's a distress experienced when the gender identity and body are not congruent. And that is the definition that we see in DMS-5. Why this is important? It is important for me because gender dysphoria means something that the individual feels. It does not necessarily translate directly to the specimen we have on the bench. And I see that typically when we get surgical affirming specimens, we typically say, oh, gender dysphoria. And I urge my colleagues on the call not to put the term gender dysphoria in your report unless you actually read gender dysphoria in the clinical notes, as this is how the individual feels about their own gender. So philosophically speaking, how are gender-affirming resections viewed in surgical pathology? Look at this table here. This is not a scientific table. This is just my own reflections as a surgical pathologist. If you talk to any surgical pathologist and ask them, what kind of specimens do you get in surgical pathology? They probably will mention one of those 6 categories. Again, this is not scientific. It's just an impression. And I'll put this before you to ask the question, where do gender-affirming specimens sit along that spectrum? Cancer resections, colectomy, lung lobectomy, hysterectomy, ovarian cancer. We all know these specimens, and we know how to deal with them. We have very defined protocols as to what sections to submit, what areas to examine in the specimen. We know very well how to deal with cancer specimens. Ruptured spleen or testicular torsion, or any strangulated hernia or any explant. We know how to examine these organs. We know how reduction mammoplasty is grossed and handled in surgical pathology. But where do we put gender-affirming specimens along that specimen? I don't think we have settled this one yet. I think in pathology, we were taken by surprise. We started to see these specimens coming to us without really someone to sit down and think thoughtfully as to how we should handle gender-affirming resections in the lab. My surgical pathology colleagues on the call now, they will probably wonder, what are you talking about? We deal with them just like that last category. They are handled like they are cosmetic or reconstruction. Really, I will show you now that this probably is not the right categorization either. they don't necessarily fit in that category, as I will show in my presentation. So leave this thought with you for now, and I will show you through the presentation that we are actually confused about how to deal with gender-affirming resections in the lab. So let me start first by presenting an inventory of pathologic finding of transgender specimens. And I think this is an important part because all surgical pathologists know that the eye only sees what the mind searches. So unless my head is looking for a cancer cell, my eye is not going to look for it, is not going to see it. So I presented this part of the talk in CAP. I have a CAP course that talks about that simply for surgical pathology to give you a menu of all the changes that you are expected to see in a transgender specimen. Because if you don't have that list in your mind as you are examining the uterus or examining the breast, probably you will look at it, you will see the finding, you will not notice the findings before you. Of course, most of the publications, I'm very proud that most of the publications used for this talk came from this very department, came from my colleagues on the call. So changes we see in gender-affirming specimens fall into two categories, hormone-related and non-hormone related. You can imagine, and that's exactly where we started. We started by studying organs that are affected by hormones. And these organs are characterized by having cells that have steroid receptors on the cells so they can respond to the hormones the individual is receiving. Hormone-related alterations, here is the inventory of organs. You see it in trans men receiving androgen. You see it in breast specimens, ovary, endometrium, cervix, vagina, fallopian tube, myometrium. In trans women receiving estrogen, you will see it in testes, you see it in penis, in penectomy specimens. Of course, these, as I said, these are organs that have steroid receptors. You see those changes, other changes in other organs as well, but we don't see these organs in surgical pathology. And I find this fascinating that just the fact that I have a uterus with me here that shows certain changes, it doesn't mean that this is all what this individual has. The individual has so many other changes in their body, in their many other organs that we just don't see because they are not part of the gender-affirming surgery. One of the things I also noticed is that the correlation between the extent of the histologic changes before me and the duration and type of androgen administration is not always linear. So I can't really predict how long the individual has been receiving hormones just by looking at the slide. This is part of the work that Dr. Klein published, changes in breast. I will present some slides to you, but I want to highlight a point here that in this one study, they realized that preoperative imaging was performed in only 83% of subjects. Think about that for a second. This is very important. Why this is important? If you go back to when I said reduction mammoplasty, what happens if a patient requests reduction mammoplasty procedure? That person is going to be examined by imaging to ensure that she has no malignant or pre-malignant lesion in her breast. And then she goes to surgery. So by the time we in surgical pathology, we receive a reduction mammoplasty specimen, we pretty much are guaranteed that there is no cancer in it. There is nothing in it because the patient obviously went through all imaging. But what I'm presenting to you here is different. I'm presenting to you that only 83% of individuals seeking mastectomy for gender affirmation received imaging, which means that 17% did not. And therefore, are we going to apply the same grossing protocol that we used for reduction mammoplasty to mastectomy for transgender? That's a question. In our institution, the number of transgender resection specimens doubled and exploded over the last few years. And as I said, there is no established guidelines as to how to sample those specimens. The way we use them, I asked our PAs, how do you gross breast specimens here? They use the same protocol that is used for reduction mammoplasty. As I said, while 17% of these patients did not receive preoperative imaging. The changes here are the effect of androgens, stromal fibrosis, lobular atrophy, and you see here on the left, lobular atrophy compared to a normal lobule. You see thickening of the basement membrane, reduced of glands. You can see changes similar to those you see in gynecomastia. Our surgical pathologists are familiar with these changes. New plastic findings. The studies showed that there was no observed increase in epithelial hyperplasia or malignancy in transgender men receiving testosterone. So we established that testosterone is not carcinogenic in these individuals. In fact, some studies showed lower incidence of breast cancer in transgender men. And as Dr. Klein points out to us, that every proliferative, every neoplastic lesion that you see in a cisgender control, you may see in a transgender man. That's a picture from her publication. Changes on the ovary, you get multicystic ovarian disease, you get thickening of the tunica. You can see the tunica here is thickened. You see the ovary has follicular cyst, almost looks like polycystic ovarian disease. Again, look at the thickening of the ovarian capsule. And this was one of my most fascinating findings, is that as you know, the number of primordial follicles steadily decreases in the female ovary as her age advances because of ovulation. But when the individual is receiving androgen, it suppresses ovulation. And therefore, you look at the ovary and you find unexpected increased number of primordial follicles. Gynecologic pathologists are very accustomed to this phenomenon. If I show this ovary to any gynecologic pathologist and say, guess what? What is the age of this individual? They will say probably this is 12 years old or 13 years old. But you will see this ovary in a 35 or a 38 individual who was receiving androgen because of the suppression of ovulation. What I'm showing you is 1 square millimeter. We had a resident here, her name was Dr. Toyama, Aimi Toyama. Poor Aimi, she sat at the microscope to count these follicles because I told her I need to count these follicles and compare them to individuals not receiving androgen to demonstrate that androgen results in relative increase in number of primordial follicles in the ovary. The endometrium, you will get endometrial atrophy. We established that androgen receptors are seen in endometrial stromal cells, and therefore endometrial stroma and endometrial gland respond to androgen, as you can see here in these images. Again, if I show you these images, you will probably say this is an endometrium from a 75-year-old, but this is an endometrium of a young transgender receiving androgen. You can see there is reduction in the number of glands, and the stroma has speculated cells, and the glands are sparse away from each other. There's even some pseudo-decidualization, and that in itself was described experimentally if that under effect of androgen, stromal cells get pre-decidualized. But we haven't seen this before, as I said, because we haven't been looking at uteruses from transgender men. And even if we were looking at them, we probably didn't see them because we were not looking for them. So now I'm pointing this out for my colleagues. These are the things you want to describe. Cervical changes. The ectocervical squamous epithelium becomes atrophic, and when it becomes atrophic, it becomes bluer and darker, making the pathologist jump into high-grade dysplasia diagnosis. And I have seen this overdiagnosis of dysplasia in transgender men with androgen administration. So if the pathologist is in doubt, they can use P16 that can help them with that. But this is an important finding because the same cervix, if I show you this cervix and say this is from a 75-year-old, you will have no problem at all. But when you have that uterus from a 25 or a 28-year-old, you will immediately think dysplasia because it is dark, cells are clustered, they are crowded. But again, if you think carefully, if you take a deep breath and read the history, you will realize that this was an individual under the effect of androgen. You will notice that what androgen does, the basal layer loses the classic palisading arrangement, and you get some layer on top that looks like umbrella cells. Certainly, you notice that some of the nuclei have long grooves, so that's what we call transitional cell metaplasia. And again, if you are in doubt, a P16 stain can demonstrate that this is not really dysplasia. It is important in our reports to document that the uterus had the cervix out for future screening. As we know that trans men are supposed to be receiving pap smears, but pap smears in trans men are very uncomfortable. They are very painful because vagina is tight and it is dry, and they resent it and they don't like it, and there is a lot of misinformation out there. So typically, if you compare trans men to cis women, you will see that trans men are behind with their pap smears. So it is important to document if the cervix was, if the individual received a supracervical hysterectomy, for example, then that definitely they need the pap smear to make sure that there is no H cell in their cervix in the future. So, do transgender individuals get HPV-related changes or not? That was an interesting question, and I used to believe that they don't, and I was wrong. And later on in the past, right before COVID, I had cases that had HPV changes. So now I'm convinced that a hysterectomy from a transgender may as well have HPV. And just because I see that atrophy, I shouldn't automatically dismiss it as atrophy. I really need to think carefully, is it just atrophy or H cell? Vaginal changes, again, Sandhya demonstrated androgen receptors in female vagina, and the vaginectomy specimens that we get will have the same atrophy, the same umbrella cells, the same transitional cell metaplasia. And what Sandhya demonstrated also in her paper is that for some reason, and I don't know the explanation of that you start to see some glands in the junction between the epithelium and stroma of vagina after administration. And these glands stain like prostate glands. So she called it prostatic metaplasia. And I think that the stains are shown here, that these glands stain like prostate glands, and when you need to look for them, and we need to document their presence, and we need to call it with its proper term, which is prostatic metaplasia. So these are some of the examples, the spectrum of changes that we see in female organs after androgen administration. We will switch gears now and talk about testicular changes after administration of feminizing hormones. As you would expect, again, you get testicular atrophy with increased fibrosis, reduced number of Leydig cells. Look at the basement membrane. There's thickening of basement membrane. There is spermatogenesis arrest, and you get some vacuolation of Sertoli cells. Again, high power. You get this nucleomegaly phenomenon and thickening of the basement membrane and reduced number of Leydig cells as a result of estrogen. Some of the incidental findings that you see in orchiectomy specimen is germ cell neoplasia in situ. And I'm showing you a case from Dr. Zong across the hall here from me, shared his case with me, that this was a transgender who had a germ cell neoplasia in situ in her testicle prior to the orchiectomy. Again, think a little bit about that and think about these testicles. If this testicle can have in situ change, so how should we deal with orchiectomy specimens from transgender? I will talk now about the case where the transgender wanted her testicle not to be examined. Is that a good thing or a bad thing? Should we do this or should we not do this? But the evidence here shows that even at this young age, a testicle could have in situ malignancy. And therefore, from the pathology point of view, I think this testicle needed to be examined. But again, as I started my talk at the very beginning, we have to acknowledge that transgender population is a very special subgroup of individuals. They have their own emotional needs, social needs, and we need to be sensitive to these needs, and we need to take care of their needs. Some of the incidental findings, you get ectopic adrenal glands, tissues, you get lipoma, you get adenoid tumor. There's nothing fancy here. But I want to highlight these two papers that came from Harvard, which these are very good studies that demonstrated the guidelines as to how these testicles should be grossed. We need two sections, one from the spermatic cord on fast for the margin, and three sections cross showing the rete, testis, and epididymis with the testis. So at least for testis, we have guidelines, established guidelines as to how to gross them. I'm not sure if we have established guidelines for other organs like vagina or breast or uterus. Dr. Morgan always reminds us that with every penectomy specimen, the penile urethra has squamous metaplasia. I asked him multiple times, do you know why this is? He said, I don't know, but we see it every time squamous metaplasia in penectomy specimens. So that was a quick review of all the changes related to hormone administration. And here is a list of, this is another review that we published with others, collected all the other changes that can be seen in transgender affirming specimens related simply to the surgery they go through. And any pathologist who handled these specimens probably has seen some of these observations: granulation tissue, fat necrosis in the surgery site, and of course our classic silicon granulomas when transgender have the surgery with silicone injection for body contouring. Sometimes when these tissues are excised the pathologist will have to report on silicon material. Incidental findings, this is one of the cases I think many of my colleagues will remember. Dr. Morgan had this case in a penectomy specimen where we found unusual collection of cells, very crowded cells. We couldn't figure out what was going on. And again, that's the beauty of our consensus meeting. We all gathered at the microscope. We all looked at these slides and we just basically didn't know what that is. And he showed it to our derm colleagues and said, well, yeah, what's wrong with you? That's a cellular blue nevus. Duh, yeah, well, we were not thinking about that. Again, it needed multiple people to look at it. It needed special stains. It needed a consultation with the dermatopathologist to arrive at that diagnosis. But again, I find these cases fascinating because you are not expecting to see these things, and you need to process this correctly. I want to talk about some screening considerations, and as I said, and I hinted to this before, that most trans men retain their cervix, either because they didn't have, as I said, most of them wouldn't have even hysterectomy, and I hope when they get hysterectomy, they get total hysterectomy with the cervix out. And I mentioned that pap smears are very uncomfortable, and abnormal pap smears should be considered, and the pathologist should think carefully about diagnosing dysplasia and HPV changes. I know there is a talk about anal cytology. I know Dr. Amin and his group had a beautiful paper that got accepted recently and will be one of our residents is presenting in USCAP about a fellow about anal cytology and the correlation with biopsy. They showed that the correlation is not good, but at least this is the state of our practice today. In trans women, breast cancer does occur in trans women and commonly presents at a younger age. And again, there is no screening recommendation for trans women as far as breast cancer is concerned. Dr. Ferk shared this paper in JAMA with me last year, and I thank him for that. That was a report coming from the VA system describing 155 prostate cancer in trans women. All sorts of individuals. Some had hormones, some didn't have hormones, whatever. Of course, the good news is that all cases were diagnosed by screening. But the bad news is, are we actually screening trans women for prostate cancer? Just think about that. Because prostatectomy is not part of surgical gender affirmation. So I can say 100% of trans women keep their prostate, and therefore they need to be screened for prostatic cancer. We'll talk about that in a second. So now, how do we get our laboratory ready for all of this? I just threw at you a compilation of changes that I only learned about in the past, 5 years, but I'm sure it's a lot more than that. So how are we ready for this? So there are informatics issues and EMR, and I know that Dr. Gibolino was talking with Dr. Gaddis about this a couple of weeks ago, about patients, individuals changing their names and whether EPIC allows this or not. And the whole issue of, I know that this version of EPIC is better than the previous one because it allows the gender to be neutral or non-binary, but we are far from safe as far as our informatics and EMR. There are whole talks about that topic, and I'm not the expert to talk about this. There are insurance implications, and reimbursement is denied when the procedure does not match the gender. Again, there is a whole bunch of literature about insurance, and that's outside the scope of this presentation. But what I want to highlight here is our grossing protocols. And when I go around the country, I talk about the topic, I meet colleagues in other states. We are very fortunate. We are way far ahead from other departments. At least we recognize these specimens, and we have good protocols. We think we have good protocols managing these specimens. But other labs across the country are just getting ready to understand the magnitude of changes and how they need to identify and develop grossing protocols for transgender specimens. The whole issue about release of specimens is another issue. If you ask the lab, do you have a policy about release of placentas? Of course, every lab in the country knows how to release placentas. Do you know how to release fetuses? Yes, of course, we have a policy about that. But do you have a policy about releasing gender-affirming specimens? I don't know. I don't know. And certainly we were taken by surprise when we ran into that. Again, we are much better today than we were a few years ago. But I still think we need to get our act together more and develop better policies about releasing specimens to individuals. And why is that important? It is important, as I said, because transgender population have their own emotional needs, and the way they feel about their specimen is something very different from how the cancer patient feels about their specimen. I will talk about billing codes, and Brooke helped me a lot with this part, understand this part, and I will talk about non-standard handling of specimens. So here's a screenshot of a white paper that came from an industry-leading billing company that specializes in healthcare, and it shows the billing codes for transgender specimens. And I'm going to go over these codes one by one. But I want to highlight here that in this white paper, they talk about vulvar resection and prosthetic radical hysterectomy. Like, oh my God, like this is how much ignorance is out there. I just said that prostatectomy is certainly not part of any gender-affirming specimen. Vulvar resection, we never received vulva in any gender-affirming surgery. So even at that level, there is confusion about what transgender affirming surgeries include or does not include. And when you go down this list, where is vagina? Vagina is a very common specimen in transgender pathology. Do we talk about it or we don't talk about it? So look at this billing code for transgender mastectomy from the previous white paper. I wanted to compare this with the billing, with our classic billing code that we get from the American Pathology Foundation coding handbook. Look at that for a second and see, we bill, or most people will bill that breast at 307. What is 307? 307 is probably what you bill partial mastectomy with lymph node for cancer. Yes, radical mastectomy would be 3.309, but lumpectomies, these are cancer specimens. Lumpectomies and mastectomies with cancer are billed at 307. So here's a question. Is it fair? Is it fair to bill a transgender mastectomy like cancer mastectomy? Is it fair, or is this overbilling? Again, going back to the philosophical concept I asked you at the very beginning, how do you regard transgender affirming, gender affirming care? How do you regard these specimens? Do you look at them as if they are cancer? Look at the uterus. We build the uterus at 307. And again, 307 is a uterus with a lot of findings. Yes, not cancer. Cancer is 309. But 307 is a uterus with fibroid. How many sections we get? How much time do I spend looking at a uterus with hyperplasia or fibroid leiomyoma? And how much time do I spend with a uterus from a transgender male? I think this is overbilling as well. I don't know. I don't know if this is overbilling. But what I'm saying is that we don't have, unfortunately, the American Pathology Foundation Coding Handbook needs to have a section for transgender billing that we agree on, and it's fair. Because if you leave it like that, people are billing any billing, and testis probably is the only one that is billed properly at 302. 302 is the testis for castration, like advanced prostate cancer. When they want to reduce testosterone, they do orchiectomy. So yes, so 302 makes sense for testicular castration. At least we don't bill it at 305 or 309. How about penectomy? How do we bill penectomy? We bill it at 307. And why do we do that? I don't know why do we do that. Because there is no such a thing in any other setting that there is no penectomy specimen that is not for tumor. Penectomy for cancer is 309, but there is no other penectomy that we can compare our penectomy with. So again, I don't know if 307 is the right billing or not. So these are just examples from that white paper to show that really billing is all over the map. Few words again from CAP checklist. Again, thanks to Brooke, helped me with that. The two items in the checklist, ANP 10016 and 10032, that talks about compliance as far as submitting specimens to the lab. And all it says is that the institution should have a policy defining the types and the specimens that may not skip pathology at all, and a policy about specimens that are exempt from microscopic examination. That is an institutional policy. And so we should have that policy. But once we have a policy, we should not deviate from that policy. Otherwise, we would be cited by CAP. So how do we deal with the person who is asking for their testicle not to be examined when we know that testis can have in situ carcinoma? So that was a challenge for all of us. And this is what we did. We came back to the consent form, and we realized that when the patient goes for surgery, they consent to multiple things. One of them is they consent for their tissues to be administered to the lab. So currently, the way we operate is the individual who doesn't want their testicle, any organ to be examined by pathology, they can cross this off and they sign next to it, and then the case will not come to pathology. We found this safer than trying to send the specimen to pathology, but then ask pathology not to process the specimen. There's so much that can be lost in translation in this workflow. Our policy is that if the individual doesn't want their specimen examined by pathology, don't send it to pathology. But if you send it to pathology, we will follow the policy that we have. If testis is meant to be examined, then testis will be examined. Is this an ideal solution? I don't know. Again, I don't know if this is ideal or not. So in conclusion, I hope I demonstrated to you that we stand in a point in time where the whole transgender care is evolving, and we just stand somewhere here. We certainly achieved a lot of progress from before, but we have a lot that we haven't achieved. If you look at the list on the right, I just compiled a list of the deficiencies, in my view, We don't have screening guidelines for breast cancer or cervical cancer otherwise. Insurance coverage, grossing protocols are not uniform. Informatics, EMR, we have a way to go. Specimen release policy, we need to tighten this. Billing codes, we need to have reasonable billing code that can be fair to the lab and fair to the individual. I think familiarizing ourselves with the inventory of findings that we expect to encounter in a transgender-related specimen will help consistent and comprehensive pathologic evaluation. And I want to remind my colleagues that a proactive approach is needed to navigate our way between the needs of the individuals and the compliance. And pathologists need to understand that this issue is much bigger than the lab and much bigger than just surgical pathology. As I showed, so many fingers are in this right now. And this knowledge have not been possible without the effort and the creation of these wonderful people. I want to acknowledge them all. Many of them are my colleagues, my dear colleagues and family. Some of them are from Saskatchewan. Of course, Brooke helped with the billing and compliance. And a special thanks to Muhammad Al-Hajj, whose comments were inspiring 8 years ago that got me to study transgender pathology. Thank you very much.
Thank you, Mahmoud. That was just wonderful. You raised so many issues that I think so many of us have not even considered before. And it's really remarkable to think about some of these things. I think Scott has a question, and Scott.
Yeah, I do. That was fascinating. Thank you very much. I learned a lot from your presentation. I'm going to come talk to you some more about some of our animal work where we've been manipulating androgens and androgen receptors. Along that line, one thing that we've noticed is the kidney in male mice is exquisitely sensitive to orchiectomy, and it will lose like 30% of its mass in a castrated mouse. I didn't see kidney on your list of tissues that are, androgen receptor positive and androgen sensitive. And so I was hoping you could provide some context for me on this, comparing rodent and human kidney.
Absolutely. As I said, kidney is not part of the gender affirming surgery. So I'm sure there are, as I said, there are changes in kidneys, pancreas, everything else, but we just don't see them. So we actually don't know. And that's why I think the topic of hormone manipulation of tissue is much bigger than what we see in surgical pathology. We are limited to the specimens we receive.
Okay, we have another question.
Thank you, Dr. Khalifa, for this presentation and for doing this work. It was very eye-opening, especially the billing codes section. I had something I was wondering about, and again, I'm coming at this as a medical anthropologist with little familiarity with pathology, but I was wondering whether chest binding affects like the chest tissue at all. So I know, people bind for transmasculine, people bind for different periods of time, years or intermittently. Yeah, and so that was something that I was curious about, whether that affects the tissue.
Yeah, again, we don't have that experience. Those kind of questions certainly should be scientifically studied. But since I'm coming from the surgical pathology point of view, we only report on what we see in the specimens before us.
And
Thank you.
Molly.
Yeah, I'll respond to that a little bit because I do deal with the breast specimens for patients with gender dysphoria. we have not looked at that specifically, and it's a very good question. I'll say that anecdotally, there once in a while we see a fair amount of periductal inflammation, and I wonder if that might be related in part to binding, but we haven't. In our study, we looked at testosterone treatment, but we did not look at whether or not or what kind of chest binding the patient had documented prior to surgery. So that's an excellent question. And I've wondered about that. So maybe we should address that. I do want to hopefully be really quick about the screening question for screening mammography for these patients. So our patients are actually overscreened, I would say, because the American radiologists, their official stance is that patients should only receive screening mammography if they would for another reason, for standard age-related reasons or for family history reasons. So if a patient is, for instance, under 40 and doesn't have a family history of breast cancer, they actually don't need screening mammography. Most of them did get it, as Dr. Khalifa mentioned. And the reason it's not recommended is because screening mammography is not very good in younger patients because they have very dense breast tissue and not much fat in their breasts. So mammography is not very good at finding things, and the false positive rate is fairly high. So they end up they see something funny, they end up biopsying it. It's almost always benign, et cetera, et cetera. So they end up getting more biopsies or even excisions than they would really need. So that, and then the last thing is about the billing is that we actually bill our transgender mastectomy specimens as reductions. It's an 88305 charge, not an 88307. So at least we are not guilty of overbilling for that. I have kind of advocated, but not strongly enough, to have a separate billing code for transgender mastectomies, just so it's just easier to search for those patients. Thank you for an excellent talk, Dr. Khalifa.
Dr. Lucat.
Yeah, I just wanted to take a moment to talk about a parallel situation that we're having in the world of products of conception, and we're actually re-looking at some of the protocols. There are actual things in the rules with Fairview that in discussions about not examining a specimen microscopically, some of the things that need to happen. And the policy actually says that you have to discuss the risks and the benefits of, for instance, not doing a microscopic exam on a DNC or a D&E. And there's directives that the OBs have to put a note in the chart that indicates that they've had these discussions about risks and benefits. So the granularity of it, at least in the POC world, is evolving right now, because we're relooking at how those directives are worded, et cetera, because they need to be even more granular than they currently are. And it's very, very much reminds me of what you talked about in your discussion about what's the proper way to frame these exclusions that aren't already exclusions, because there's a list of things that don't require microscopic exam. So how do you handle situations when it's not in the list and you obviously don't have time to redo hospital bylaws in the space of a specimen? And I think this is the kind of rule that will fit in there, a generalized rule that allows you to override as long as risks and benefits are stated by the doctor as being discussed with the patient.
Yeah, I personally really worry about this a lot, Mark, as you know, because we are not the ones who actually do the education for the individual. We don't really control that process. B, we don't know what is actually said. If a person crossed off testicular submission to pathology and just signed of it, and the testicle did not arrive to the lab, are we off the hook here? Is that the best thing for this individual? That at the moral level, and not the legal level, legally probably we are okay, but did we really serve the individual? As I said, especially since I am not the one who did the education. If I did the education, if I'm allowed to talk to the patient, I will actually show them that cancer that Dr. Zong gave to me and say, hey, this is what you could have in your testicle today. Do you still want to take your testicle without coming to the lab? So yeah, I hear you. I hear you. As far as we are concerned, we need to be compliant, i.e. we need to have a policy and we need to follow the policy. That's all we can do for now.
Well, as you pointed out, just scratching something off doesn't give you a lot of information. In our case, the OBs will actually say they've discussed the risks and the benefits, but you don't really know what that means. Yeah. So, is it overkill to go to the next step and actually have a form? And when they want to deny microscopic examination, they have to sign the form. And on the form, there's a list of the organs and conditions. So they're conveniently in one place, and they check off the box next to POC. And that box says, I realize that not examining the specimen, it's a possibility that there's a cancer that is being missed. And then they would be acknowledging it with in a very granular way. They understand what they're doing.
Well, we want to thank Dr. Khalifa again. We're past our time, and obviously this was a talk that really resonated with so many of us. And thank you so much, Mahmoud, for doing this. We really appreciate it.
My pleasure, Debbie. Thank you. My honor.
Thank you. Good day, everybody.
Thank you.